Good morning, esteemed doctors. I am grateful to the organizers for the opportunity to share my experience. So today I will shed light on spinal OA from a physio perspective, focusing on the theme back in action, exercise to realign and strengthen. So this would be the core content, which include the assessment, mainly the posture and the gait assessment, management of low back pain, then physical intervention, plan of treatment and exercises. Now let's consider an analogy. Imagine I have a budget of buying a high quality car with a top-notch suspension, which I don't, but okay. But instead choose a low quality car with a poor suspension. Now the suspension role is to avoid and protect you from the bumps and the speed breakers on the road. Similarly, our spine and a body is compared to a car, and the core muscles are our suspension. Suspension determines the quality of the car. Our body, the muscles determines the strength of your spine. Over time, both the spine and the car is going to wear out. Your spine will have disc degeneration, your spine will have facetal arthropathy, but a good suspension and a strong core can keep you functional. Now let's go through the assessment, which will include mainly the posture and the gait. There are other parameters to assess, which is the muscle charting, the myotomes, the dermatomes, but which you all are already aware of. So the postural assessment. Now posture is how a body is positioned at any movement, involving all the joints of the body. Each joint affects the other. A posture from side looks like a straight line running through the earlobe, cervical vertebrae, shoulder, mid of the thorax, lumbar vertebrae, and just behind the hip, slightly in front of the knee and in front of the ankle. So we'll go through different postures, and in all of it we'll just see that what happens to the segment, what muscle gets shortened and what muscles are getting elongated. So this is the most common posture which we all see, which is the exaggerated lordosis. Now here, if you all can see, there is increased in the lumbar lordosis, there is anterior pelvic tilt. So whenever there is a posture, there are changes from the cervical up till the ankle joint. But we'll just go with the main segments. So the muscles which are getting elongated here are the anterior abdominals and the hamstrings. The muscles which are getting shortened are the lumbar erector spinae and hip flexors. Now the next common posture which we see is the sway back posture. Here there is long thoracic kyphosis. The pelvis is anterior to the postural line. The lower lumbar segment is flat. The pelvis can be neutral or it is into the posterior tilt. Here the elongated muscles are the hamstrings, hip extensors, shortened are the hip flexors and the obliques. Now we'll see the round back posture. Here the body segment alignment which we see is the head is forward with cervical hyperextension. There is increased thoracic kyphosis and the head is ahead of the postural line. Here mainly the muscles get elongated are the upper erector spinae and shortened are the neck extensors. Flat back is also a very common posture. Here there is loss of lordosis, the patient is into posterior pelvic tilt. Then the muscles which are elongated are mainly the one joint hip flexors and the lumbar extensors, shortened are the hamstring and abdominals. The next is the kypholordotic posture. Now this posture is a mixture of the round back and the lordotic posture. So the importance of knowing the posture is to know what to stretch and what to strengthen. Now we'll go through the gait assessment. So there are two phases of gait. One is the stance phase and the other is the swing phase. So various muscles are used in different phases of the gait. For instance, in the initial contact, the trunk is positioned in between the lower limbs, the two lower limbs, while the pelvis is in a level. Then when you walk, the pelvis medially rotates on the side of the initial contact, along with there is 20 to 40 degree of hip flexion. Now, in order to resist the hip flexion action at the hip, the G-max, the gluteus maximus, and the hamstring has to work eccentrically. And at the spine level, the erector spine have to work eccentrically to control the trunk forward flexion. Now, similar to this, distinct muscles have distinct responsibility, providing a clear picture of how is it affecting the spine. So the common abnormalities in walking are seen at the trunk level are the forward lean, the backward lean, the right lean, left lean, rotations. On the pelvis, it is the anterior pelvic tilt, the posterior pelvic tilt, there is pelvic hike, there is a lack of forward rotation or backward rotation of the pelvis, there is ipsilateral drop, contralateral drop, which is commonly seen in the models. Now, according to the WHO guidelines, this is how OA spine is addressed. There is a structured and standardized education advice given by the doctors, physical interventions seen by the physios, multi-component interventions, which we already went yesterday through the obesity management, medicines and psychological intervention. Now let's discuss the physical intervention. The physical intervention mainly comprises of the active physical intervention and the passive. So active is mainly the structured exercise protocols, which is strengthening, there is stretching, there is Pilates, there is Tai Chi, there is aerobic exercises. Passive is mainly the manipulations, the needling therapy, the cupping therapy, electrotherapeutic modalities, which is the TENS, IFT, which we all are aware of. But the main goal for a physio is to look more for the active intervention, because at the end of the day, it's the patient who has to go back to his active, functional life. So now let's take a case scenario. So this was a patient which was 73-year-old with low back pain radiating to the periphery since 3 months, difficulty in walking, standing more than 2 minutes, with claudicating pain which started after 5 minutes. Then the NPRS was 8/10. The MRI showed L5-S1 retrolisthesis, canal stenosis, osteophytes, facetal arthropathy. So according to the doctor advised physio, which mainly he told us to focus on the SWD, TENS, mobilization, stretching, strengthening. Now SWD has been shown to be beneficial in pain management over time. However, literature showed that it should be avoided in osteoporotic patients as there is an increased risk of compression fracture. The same is true with the back static exercises, which have been revised to feature a better core program. Ideally, in my patient, flexion biased exercises are given in stenosis and extension biased exercises are given in retrolisthesis. So, but in my patient, because both cannot be given, she had retrolisthesis as well as stenosis and facetal arthropathy, so even extension was to be avoided. So, I started with neutral spine exercises, which proven to be more effective. Seeing to it that the spine is in neutral and the patient is using its core. So by the end of week 1, the NPRS was 5/10, claudicating pain after 15 minutes, and there was no change seen in the peripheral symptoms. Now by the end of 2 weeks, there was an improved core recruitment seen, the gait was improved, there was centralization of symptoms. So started with a little nerve mobilization to reduce the heaviness and improve the recruitment of the muscle and centralization of the symptoms. Along with the core recruitment, I started working on the gluteal recruitment and the lumbopelvic stability. So by week 4, there was 30 minutes with no claudication. The NPRS was again 5, it was 5 same only, and the peripheral symptoms were slightly reduced. Now the next was after 4, the strengthening phase. So by week 4, started with loading exercises for the core and more stability exercises involving more functional activity. Resistance training was given for the gluteus, focused on the lumbopelvic stability to reduce the relapse and work more towards her discharge. So here the patient is able to keep the spine neutral. And with the core, she was able to do the tabletops. Here is the gait training. So in the first video, you will see there is a list towards the right. This video was taken on day 1 with pelvic drops, significant sway, antalgic gait, poor lumbopelvic stability. The second video shows improvement in her list. This was taken by the end of week 2. And her gait is better, the pelvic drop is reduced, there is still lumbopelvic instability but improved. And this was taken by the end of 4 weeks, which was, you'll see a good lumbopelvic stability, there is no drop, there is no list, and the patient is managing with resistance. Now we'll come to the exercises. So let's imagine the core is like a box. The upper layer is the diaphragm, the lower is the pelvic floor, the anterior is your transverse abdominis, and the posterior is the multifidus. Multifidus, so we'll go through the exercises now. The multifidus, it's a crucial muscle that often gets overlooked, and it's a new powerhouse because your spine to stay in neutral. Multifidus is a really important muscle. So here there is neutral spine, and maintaining the neutral spine, we have to work on the loading of the multifidus. The next muscle is the transverse abdominis, again a crucial muscle, and here also the patient is first told to be in neutral spine. So here the pelvis is going into anterior tilt, posterior tilt. We have to tell the patient to be in the center of it and then lift both the legs in tabletop without losing the neutral spine. The pelvic floor, which is these two exercises have been, concepts have been beneficial, which is the elevator technique and the Kegel exercises. Then the diaphragm, which is the major muscle of breathing, we all know about, and known as the core tent. Then the gluteal strengthening. So we have to work on the gluteus medius, maximus, and all, and the minimus, all three. Then is the thoracic mobility exercises. Often reduced thoracic mobility can make you more prone towards reduced lumbar stability. So it is important to open up the spine.
Shital, 2 minutes left.
Yeah. Play the video. Then the nerve glides, which we already seen. It can be given for the sciatic, the femoral, the obturator, all the nerves. Then important two concept, which is compensation and dissociation. Now compensation is an uncontrolled movement happening at a level which ideally shouldn't move while doing exercises. For this video, so this is dissociation, the concept in which we need to treat the spine as a different segment. There should be cervical mobility, there should be cervical, thoracic, and lumbar needs to be addressed differently. The second video. So here, this is the action of the gluteus medius, but if it's not monitored, this is the action of the quadratus lumborum. So you have to see if the patient is using the gluteus or he is using the quadratus lumborum. Now the myths and facts. Longer duration of bed rest should be avoided. In acute phase, obviously rest is recommended, but not long. Then the limiting range of motion. So it's important for us to not mention to the patient that don't bend, because the patient doesn't bend for his entire life. Then use of modalities, the doctor's favorite is the SWD. Then even that should be reduced. It should be a physiotherapist And all the doctors should be looking for the long-lasting effect and not just the symptom reliefs. There should be the functional goals should be our main priority, for which phasic loading of the spine is important. We should not mention the number of sessions which would be needed. An ideal posture is a myth. We have to work for the postural optimization. And the tips which you can give to the physios are you'll have to mention the red and the yellow flags. It's important for you all to know that motion is lotion, and trust your physio, and always ask a short summary from your physio that what all he has assessed and what all the treatment is going, what is the progression. And like all the other checkups, there should be an annual movement checkup.